Welcome to Veda Lymphatic University. My name is Lowell Kabnick. Today we're going to talk about the Fortegra Venous Stent. What do we know and the clinical trial data? The stent received FDA approval on January 6, 2026, and has a breakthrough designation as the first stent to have iliocaval indications. Today we're fortunate to have Steven Abramowitz as a speaker, also global physician investigator, and discussants Kush Desai, also a global physician investigator, Khanjan Nagarsheth, and Anil Hingorani. Steven, the floor is yours. You care to share the slides?
Absolutely. Well, thank you for having me and a great introduction to what we're going to be talking about for the next 10, 12 minutes. This discussion is primarily focused on the Gore Viabahn Fortegra IVC stent and the data that we have available to discussing the stent and why it's so important. As it was just alluded to, there hadn't been a prior FDA-approved dedicated inferior vena cava stent, and we know that for the majority of patients presenting with venous stasis ulceration with a history of post-thrombotic disease, 37% of them are going to have some degree of caval involvement, either at the confluence or extending up to the renal caval confluence, and that disease needs to be addressed. Historically, the wall stent had been used for treating inferior vena cava occlusive disease, either post-thrombotic narrowing or malignant compression or not or other compression disorders. But the wall stent had limitations, particularly with regards to its braided design, its size matrix, and the fact that there weren't dedicated trials, only retrospective analysis that were justifying its use in the inferior vena cava. So many people were either using the wall stent or engaging in a double barrel conformation of FDA-approved iliofemoral stents. These stents also have limitations when used in the inferior vena cava. So Gore came to market and with trial for the Viabahn Fortegra stent. And what you would notice in the size matrix here is unique to the stent's design were the 20, 24, and 28 millimeter diameters that were made in lengths of 50, 75, 100, and 150 millimeter lengths. This stent is made of a singly braided nitinol wire that is held together by a ePTFE or polytetrafluoroethylene polymer lattice. So this means that the stent has unique biomechanical properties. In addition to the fact that it has a size matrix dedicated for the inferior vena cava, it also allows the stent, because of the ePTFE lattice, to engage in axial loading, which is an up and down compression based on respiratory variation and movement of the inferior vena cava with the diaphragm or different positions of the patient. And additionally, it gave superior radial strength as well as crush resistance because of the way the stent was designed with that single nitinol wire without a braided lattice, which can be prone to areas of lower crush resistance and lower resistance to biomechanical forces that are extrinsic, as we would see with the wall stent historically and has been published on previously. There are two trials involving the Viabahn Fortegra stent. And the one that we're going to talk about today is the inferior vena cava trial. And the inferior vena cava trial involved the iliofemoral reconstruction because most of the patients who were in this trial, of the 89 that were enrolled, had confluence disease requiring extension of the stent. I would just make note that there is an ongoing enrollment for a dedicated iliofemoral indication for isolated iliofemoral stenting using the Gore Viabahn Fortegra system, but we're not discussing those results today as that trial is currently enrolling, and those results will be published at a later date. Looking at the patients who were involved in the IVC trial, 89 devices were implanted. 12-month follow-up was completed for 86 of those patients, and the goal is to follow these patients out to 5 years. A total of 129 patients will be enrolled throughout the United States and Europe in totem, but the original data analysis for the FDA was on these 89 patients. This is an example of a patient that we included in the trial. This is a patient who had a Ewing sarcoma that was resected many years prior, and at that time had a DVT extending into the inferior vena cava, which was treated with anticoagulation alone. We can see that the IVC was reconstructed using the Gore Viabahn Fortegra stent, and then the confluence was recreated using extension of 14 millimeter by 150 millimeter Fortegra stents into the bilateral iliofemoral segment. Looking at this patient population, again, this is the first real data set we have for iliocaval reconstruction in a prospective manner, particularly focusing on an IVC stent. And a couple of things that I would highlight here is this is a particularly complex patient population with almost 80% of the patients presenting with greater than 90 days of symptoms. And additionally, one of the things I would highlight is the vast majority of these patients had C4, C5, C6 disease. They had a history of IVC filter-related IVC occlusion, and to be enrolled in the trial, the IVC filter had to be removed. But in post-trial release, we have seen a lot of utilization with crushing of the IVC filter. All that data is not part of this trial. Another interesting thing to note based on the complexity of this patient population and what was studied is that this is the trial that has the greatest stented segment length recorded to date. And when we look at the majority of the patients in this trial, 83 of the patients who were followed out had bilateral iliofemoral reconstruction. This is a confluence reconstruction architecture that most mimics our natural reconstruction, our biologic anatomy. And it has the greatest total stented length of any trial that's been published to date, with an average of 41 centimeters of total stent segment treated. When we look at the composite endpoints, the trial did reach its goal with a freedom of composite primary endpoint events at 74.7%. The historic rate was set at 58%, and this is anything that was related to device-related procedural death, clinically significant pulmonary embolism, any injuries, bleeding complications, as well as a loss of primary patency or any evidence of stent fracture or stent embolization. The patency of the iliocaval reconstruction was 83.4% in primary patency out to our 12-month mark. And we continue to see that there is great retention of that patency when we look at freedom from any target lesion revascularization or target lesion recurrence. Additionally, when we look at secondary patency, we're able to approach 95% at the 12-month mark. And these are those patients who may have rethrombosed due to poor inflow or difficulties with anticoagulation adherence. In total, one of the nice things that we see in this patient population is that there's an improvement of symptoms. And again, these patients were very complex in that C4 to C6 category, and we saw statistically significant improvement in pain from baseline. This patient reported. And so when thinking about how this stent architecture can make a role, one of the things that's been done with this stenting patient population is a real focus on hemodynamics and why confluence reconstruction, that 2-in-1 reconstruction, and the need for an IVC stent may be better for patients over the double barrel technique. And so using computational fluid modeling, comparing double barrel reconstruction with other FDA available stents and also the Fortegra stent in this computational model, comparing it to the confluence reconstruction architecture, what was found is that confluence reconstruction better mimics our flow rates throughout the stented segment, as well as our mixing coefficients within the stented segment to baseline. So we set a series of inlet boundary conditions using MRI data that's been previously established for understanding fluid dynamics within the inferior vena cava segment. And then we assess this in 5 different planes: in the iliofemoral segment, near the confluence, in the midpoint of the IVC, near the renal caval confluence, and at the renal caval confluence. And then this is a computational fluid analysis looking at mixing coefficients as well as velocity in comparison to our baseline. Your baseline is all the way at the left side of the screen. And when we look at confluence reconstruction from a fluid dynamics standpoint, even just an eyeball assessment of the color and the mixing coefficients really show that confluence reconstruction with a low confluence does a better job of better mimicking both velocity and mixing than our double barrel reconstructions. The slower velocities that we see at the borders of the stent and the double barrel reconstruction can be associated with in-stent fibrosis or in-stent thrombosis, as well as increased pressures and a loss of respiratory variation, pressure variation along the stented segment. And this is, again, those 5 different planes that we assessed in comparing baseline all the way through our architecture configuration with the 2-in-1 conformation. Comparing this to our baseline, just varying by the planes, we see that, again, confluence architecture with that low confluence recreation in a singular IVC stent does a better job of mimicking our natural baseline pathophysiology. And this gives improved mixing efficiency both in our axial evolution of how the flow is moving throughout those stented segments, as well as variation throughout. Somehow I lost my last slide. But the key thing here in terms of discussing the data is thinking about why we see such positive results in our primary patency and secondary patency in this first IVC dedicated stent trial. And it goes beyond some of the biomechanical characteristics I highlighted with this axial loading specific to this design by having the polytetrafluoroethylene as the interstices of the stent, connecting the crowns of that nitinol wire that goes around as opposed to metal, making a stiff and rigid tube, but also that a dedicated IVC stent of singular overlap, no need for multiple stents because of a limiting matrix, will better allow us to create a base in our mixing coefficients as well as our computational fluid dynamics. So with that, I'll open it up to any questions or discussions.
Steven, that was brilliant. Thank you very much. Of course, I have a few questions to start with, but it's interesting that there was certainly a need, and you explained the need from a pathophysiological point of view of how the cava reacts to inspiration, expiration, et cetera, et cetera. And I think Raj Raju really understood that when he looked at the confluence, and when there were double barrels, he used a Z stent, and that made sense there. So I give him a little credit to start with that. We've learned a lot from our colleagues in Europe of what to do and what not to do, and we've learned how to accomplish that, especially with longer stents and sizing to prevent certainly migration. My question to you is the ability to jail the renal vein with this stent, and what apparently happens, because I understand it does not. Is that correct?
Yeah, it's a great question. The venous system is a very sensitive system. So you could have someone hustling and running around with increased venous return, like Kush is running through the hospital there, or you could have all of us who are sitting and relaxed and really reliant on changes in our intrathoracic pressure for venous return. But at the end of the day, it's that flow rate and maintaining flow through the interstices of the stent that's going to be important for preventing fibrin sheath or for platelet deposition and endothelialization that could lead to thrombosis. One of the concerns people had with the Fortegra stent in its original design is that EPTFE lattice would function more on the covered stent spectrum than it would on a bare metal stent spectrum. When you look at the area differential between the commercially available bare metal stents and compare it to the Gore Viabahn Fortegra stent, it is just percentage points difference into what of the interstices is covered by that EPTFE lattice. Aaron Murphy is currently working on a sub-analysis of the patients that were enrolled in the trial, looking at patency of the internal iliac veins, the profunda veins, as well as the renal veins after the stent is deployed. But so far, we've seen no signal that the EPTFE is functioning like a covered stent, is increasing risk of thrombosis or confluence vessel stenosis or thrombus deposition.
Well, thank you. I'm now going to turn it over to Kush Desai, who can comment. He certainly was one of the global investigators. And thank you for joining us even out of the procedural room.
No, I appreciate it. Thank you. And actually, I'm now on my laptop here. So one second. No, pleasure to be with all of you. Sorry, it was a little bit of a hustle bustle. The question of jailing side branches certainly needs to be borne out in the data, but I will tell you from my clinical and personal experience, the renal veins, if you think about atresia patients, for example, they don't have direct caval continuity. They usually recanalize and redistribute via adrenal pathways. And so, you'll see a caval atresia patient, and you'll see, if you look at the CT scan, you'll see a large azygos and hemiazygos, and that's how the kidneys are draining in those patients. Open aortic repairs, certainly, I'm not a surgeon. You guys know that left renal vein sacrifice was not uncommon for an open surgical aortic repair. So, and you didn't lose a left kidney. So maybe it's a little bit overstated as to what to worry about. About the only vein I would be critically aware of in doing a caval reconstruction is the hepatic vein. You cannot bag that vein. There is no natural collateral pathway for that. And I have seen more than once patients end up with post-sinusoidal portal hypertension. So, but again, worthy of study. The other thing I would say, and you all briefly covered this, is breathing dynamics, cable dynamics. This stent can axially load. No other stent can do that. Whether that makes a difference or not, that's something that we need to see. But so far, the results have been encouraging. And I'll just tell you, with a longer stent, the cases are easier. I mean, that's not the hardest part. Deploying the stent, getting across is the hardest part. But having one, in my case, I usually use a 150. I mean, from an economic standpoint and from a procedural flow standpoint, it's really nice to have.
Thank you. I do have a question to both of you with regard to incorporation. So in theory, an open cell stent incorporates. And have we seen, is the flexibility of the stent compromised by the incorporation? And the idea in terms of the reason that it was developed, could that be compromised? Have we seen any problem?
Doesn't seem like it so far. I mean, Steve and I have both placed a number of stents across the ligament into the common femoral vein. And I will tell you, again, very anecdotally, it seems to be more comfortable. But that's about as anecdotal as it gets. It does seem to be more comfortable for the patients.
Anil.
So you pointed out the patency rates are excellent and they're remarkable. And you went into a little bit about why you think they're so much better than the traditional stents that we have. I would like to ask you a little bit when not to place these stents. When are the contraindications and when did they fail? Especially as you went out towards the 12-month period, where were the failures from?
Yeah, I think one of the things I would say is in this trial, you had a lot of high volume and experienced operators. The trial design took place prior to the July classification being published. But all of the operators were operating under the assumption that inflow had to be adequate for stent patency. So for any stent, regardless of whether it's part of this trial or we're discussing it with regards to the general spectrum of post-thrombotic syndrome stenting, you still need to have adequate inflow from the femoral vein or the profunda vein, preferentially both, in order to maintain stent patency. And so we're looking at really high patency rates for patients who have extraordinarily complicated iliocaval reconstruction. But the key thing I would highlight is that all of these patients were deemed by high volume operators to have adequate inflow to sustain stent patency. And I think that's a very important point because if you're comparing apples and oranges down the road into general use, if someone has poor inflow, they're still going to have poor patency.
Yeah. No, completely agree. It's a function of, it's a bit of a selection bias based on who enrolled in the trial and who was part of the trial. The only other thing I would add is we all know this from having experiences is to be careful of patients with retroperitoneal fibrosis or retroperitoneal radiation. That's you have a non-compliant retroperitoneum and the possibility of a fracture where you have free extravasation is real, or fistulization. It's happened to all of us. So it's rare, but it's described.
Anybody, Anil, any other comments? I do have you.
Anticoagulation post-procedure, what did you do for the study and what are you doing for your patients with this particular, because these are very complicated patients and everyone seems to have a different opinion and the data is weak.
My general philosophy is, it goes back to what you said, is that these are very complex patients, and my desire to debulk them or lyse them or deal with an occluded stent is very low. Because of the post-thrombotic disease that they have, for the most part, if they're not already on lifelong anticoagulation, if you're getting an iliocaval reconstruction in my book, you have now merited antiplatelet therapy and lifelong anticoagulation. That's my general philosophy. I do recognize we need more data to support that, but that's my practice pattern.
Kush?
Yeah, I mirror that. It's at least a couple years, and I generally I generally go off of whether they're provoked or unprovoked, and if they've had multiplicity of events. If they had multiplicity of events, they're on lifelong AC. At some point, maybe go down to low intensity DOAC, apixaban being my preferred. The one thing, maybe Anil, this is what you're striking at with the question is in the peri-procedural period and in the long term. In the peri-procedural period, Bill Marson wrote about enoxaparin. That's about the best data we have. Kudos to him. It's still limited, still single center. And that's what we do. Heparinoids have an anti-inflammatory effect, so we do that. If they're at the very high BMI end, just to save us all, we'll do fondaparinux because you max out at the 10 milligram dose and they're not giving themselves large volumes of Lovenox twice a day. Antiplatelets, I've gotten less aggressive about them. I don't do DAPT ever. And I'll do an aspirin 81. And the first time somebody has, epistaxis or they have heavy periods or something like that, antiplatelets are first to go. You have to keep the anticoagulation. And then long-term apixaban.
I have another question. Seeing that we see a lot of patients now with GLP-1 drugs on board, have you noticed any, I'm sure the patient population that have these issues certainly tend to be on the larger side and probably taking GLP-1. Any cautions, recommendations?
The only thing that we've been debating a lot at our institution has been those patients who have active and aggressive weight loss and the appropriate dosing of their DOAC, as well as if there are any other nutritional barriers to maintaining their anticoagulation or testing for Plavix resistance. And so that's something that's come up repeatedly with our hematology and our pharmacogenetics group.
And what have they found?
So for patients who lose greater than 50 pounds of weight, they've been reducing their Eliquis dose. I haven't necessarily agreed with it, but that's we've been going from 5 BID to 2.5 BID. And for those patients who are not eating and they're showing signs of vitamin deficiency or other sorts of nutritional deficiency where they're losing hair or we see other temporal wasting, in those cases that they've recommended testing for Plavix resistance.
Interesting. Kush?
Yeah, the big thing is GLP-1s, one around the procedure. Anesthesia has to be very careful and you have to discontinue. That's probably being more broadly understood. We as proceduralists tend not to care. They're the ones that do. The second, it's like, okay, do whatever.
Yeah.
The second issue has to do specifically with rivaroxaban. If you have a GLP-1 inhibitor patient, they're not eating, 20 milligrams of rivaroxaban won't work. They're not getting the caloric need at the same time every day for that drug to be absorbed. Anything over 15 will not be absorbed unless there's a 600 calorie meal. So a stronger point for apixaban in those patients.
Well, thank you for that. KJ, thank you for joining. I know you were busy. Do you have any comments on this new stent? Are you familiar, et cetera?
Yeah, no, I've used it a handful of times. It's a really nice conformable stent. I think the combination between radial force and flexibility is very unique compared to the other venous stents that are out there. I also love the fact that it's covered with ETFE with open cell design, similar to the old Fortegra stent. So it gives me kind of hope that maybe the nitinol won't be in contact with the bloodstream.
Thank you very much. I do have another question before we round out. Now, we knew that there was a need for the Iliocaval type of stent. And what was the idea behind now using it in the iliofemoral for maybe nivels or for obstruction? And how would that differ from the stents that are on the market? And just this is theoretical.
Yeah, the devices are the same. The need for that trial is largely regulatory. It's the same device. And I think as we've seen with non-thrombotics, we expect uniformly high patencies. Probably not a real need for anticoagulation in those patients, certainly nothing long-term. And I expect that to be the case with this.
Is there a need for another stent, Kush?
Is there a need for another stent? No,
That's a 24
probably not.
minute. I'm sorry.
No, you know what? Listen. The nice thing about this device is that with this device, you can treat the entire spectrum of venous disease on label. That's probably the easiest way to say it.
I think that's meritorious. Stephen, last comments?
Yeah, I would say we've learned a lot, and particularly if axial loading and biomechanical design play out into improved patency. But if that's the case, that suggests to us that there are design iterations that are best suited or better suited for different anatomic locations. So we may find that there should be variability for those stents that cross the inguinal ligament, stents that are at a confluence point, stents that are dealing with deep venous reconstruction for the SVC. So I think this opens the door for us to consider the need for improved stent design in our next generation.
Well, thank you very much. And I'd like to thank Stephen and Kush and Anil Hingorani and KJ for joining us. We are going to take a break from Grand Rounds until September 9th. So the rest of you have a really good summer, and we'll see you back on September 9th. Thank you very much.